सोचा कि आपसे इंटरेक्शन करना ज़रूरी है। तो इस बार हमने वेल इन टाइम मेजर लिए हैं। हमारे 2 सेक्शंस हैं, हेल्थ डिपार्टमेंट है और मेडिकल कॉलेजेस हैं। हेल्थ का डॉक्टर हरजीत आपको ज़रूर ब्रीफ करेंगे। मेडिकल कॉलेज का पार्ट मैं बता दूं कि हमने मीटिंग ली और इसको बड़ा सीरियसली लिया अबाउट द मैनेजमेंट ऑफ डेंगू। तो हमने एक वे आउट और एल्गोरिदम बनाया है जिसके हमने पूरे फ्लैक्स के जो बोर्ड्स हैं हर जगह डिस्प्ले भी किए हैं पेशेंट्स के लिए और इवन हमारे स्टाफ के लिए भी कि जो पेशेंट मेडिकल कॉलेज फीवर से आता है मॉर्निंग आवर्स में कहाँ जाएगा और इवनिंग आवर्स में कहाँ जाएगा। तो मॉर्निंग आवर्स में ओपीडीज़ में जाएगा, मेडिकल ओपीडी में, और इवनिंग आवर्स में इमरजेंसी में। ही विल बी अटेंडेड टू प्रॉपरली। और ये भी बताया कि उसके बाद जो टेस्ट करवाने हैं उसके कहाँ उसको हमने एरिया डेजिग्नेट कर दिया उसको, ताकि कन्फ्यूजन ना रहे। और टेस्ट की रिपोर्ट 6 से 8 घंटे में आ जाती है और नेक्स्ट डे आके हमें रिपोर्ट करेगा कि उसको डेंगू है या नहीं है और अकॉर्डिंगली ट्रीटमेंट दिया जाएगा। जो सिक पेशेंट है दे विल बी अटेंडेड टू इमीडिएटली। उसमें कोई उसके लिए वार्ड्स डेजिग्नेट कर दिए हैं हमने जीएमसी में भी और पेडियाट्रिक सेक्शन में भी। तो उसमें मेन इशू जो हमारा रहता है कि प्लेटलेट्स जब फॉल कर जाती हैं तो बहुत प्रॉब्लम आती है। मेन प्रॉब्लम हमारी यही आई है पिछले कुछ सालों में। तो इस पर हमने इंश्योर किया है अवेलेबिलिटी ऑफ प्लेटलेट्स। जो मशीन्स हैं मेफेरेसिस मशीन्स हैं वो 24 आवर्स चलेंगी। ब्लड बैंक की डॉक्टर मीना यहाँ बैठे हैं, आपको बेटर ब्रीफ कर पाएंगी कि हमने रोस्टर बना दिया है अपने टेक्नोलॉजिस्ट का और डॉक्टर्स का। दो मशीन है हमारे पास, दो 24 आवर्स अवेल। हाँ, प्लेटलेट्स देने के लिए डोनर्स को इनकरेज कीजिएगा। डोंट एक्सपेक्ट कि मेडिकल कॉलेज प्लेटलेट्स रैंडम यूनिट हम दे सकते हैं, लेकिन एक प्रोसीजर कहते हैं एसटीपी, सिंगल डोनर फेरेसिस। एक ही डोनर से प्लेटलेट्स निकाली जाती हैं और ट्रांसफ्यूज की जाती हैं। उसमें क्वांटिटी और यील्ड ज़्यादा होती है और पेशेंट की लाइफ हम ज़्यादा सेव कर सकते हैं। और वही डोनर 4-5 दिन या हफ्ते बाद दोबारा डोनेट कर सकता है। तो पब्लिक से रियली गुजारिश है कि कई लोग बाहर चले जाते हैं, बड़े 25-30 हज़ार एक फेरेसिस पे खर्चते हैं विदाउट रियलाइजिंग ये फैसिलिटी हमारे जम्मू में अवेलेबल है या नहीं है। तो आपके थ्रू ये मैसेज स्प्रेड करना चाहते हैं, पैनिक ना करें। अगर ऐसा कभी है तो इमीडिएटली हमारे डेजिग्नेटेड वार्ड्स डॉक्टर्स के मिलकर डेजिग्नेटेड वार्ड में एडमिट हो जाएं। हाँ, प्लेटलेट्स हम मॉनिटर करते हैं डे बेसिस पे, या जैसे भी जो हमारा मेथडोलॉजी होती है प्लेटलेट्स मॉनिटर की जाती हैं। और अगर फॉल करती हैं तो मशीन्स अवेलेबल हैं, डोनर्स आपको ज़रूर अरेंज कीजिए। और सोसाइटी को भी बोलिए कि प्लेटलेट्स देने के लिए पीछे ना हटें स्टाफ जो हम। इसी तरह हम अपने पेशेंट की लाइफ सेव करना चाहते हैं। मेरे बाकी कंसल्टेंट्स भी आपसे इंटरेक्ट करेंगे, आप प्लीज़ कर लिए। कोई कुछ पूछना है आपको?
To cover our preparation for dengue, as you know, in the last year also we had number of patients of dengue and we managed them very successfully. I can say in SMGS we had around 1300 patients of suspected dengue, and out of which 693 were positive for dengue. And I can share, unfortunately we lost only one life. That too patient was from UP, and patient had come to Shri Mata Vaishno Devi, and child was had not fully recovered, and the parents, they brought the child there, and child well complication there, and we tried our level best, but we could not save that. But barring that, all the other patients we were able to save. Similar was the position in the medical college. I think Dr. JB will tell about the situation in medical college.
As far as Department of Medicine is concerned, I am associated with this disease for last I think many years. We get many patients. I think in last year we had around 800 patients, and last year there were 600 patients. Means there was rise of 200 patients last year. And most of the time, as far as the hospitalization of this patient is concerned, we manage the patients on the outdoor basis. We select these patients depending upon their severity of the disease, and only those who have got the warning signs, who are sick, we admit those patients in our ward. And we have designated emergency area, one floor we have kept for such patients who are sick. And once the patients are stabilized, we shift these patients to ward 3. And we have got fully, as far as manpower is concerned, as far as logistics are concerned, we are fully prepared to handle this disease. This disease has started, season has started, and we expect more cases in coming few months. So we are fully prepared for this disease now.
As far as SMG is concerned, we deal with pediatric patients, and you know the dengue in pediatric patient is severe because This is said that is the second episode, secondary infection. This is more dangerous, and the babies who are less than 1 year, they are, because mother must have suffered in the past, so we treat them as secondary infections, and but we geared for that. We had one pediatric ICU. Many of your media brothers and sisters, they had been to SMJ's hospital. We have now established new PICU that is 14 bedded. The old PICU that is around 10 bedded. We are dedicated for the dengue severe cases. Those who are in shock, those who need immediate attention, monitoring, ventilation. So we have kept that. And after that, step down ward, we have kept around 40 beds in our ward, in ward 19. Those beds are for the, after we stabilize these patients who are very serious, and the discharge after, because we have the discharge criteria which we were following earlier also. One day patient should be free of fever, and platelet count should be more than 50,000. There is no vomiting, and child is active. Then we would discharge those patients. So this year also. And fortunately, we have very good support from the Department of Pathology, from microbiology, blood transfusion, because platelet, as far as platelet is concerned, there is a wrong notion in the minds of people that we need platelet transfusion. We hardly need it. Even if platelet goes down to 10,000, then we give platelet. Otherwise, there is no need to give platelet. And below 20,000, we just observe the patient. But at the same time, if we need, we have fully functional unit, 24-hour. Dr. Meena, HOD blood transfusion, she is always there. She is heading that department, and we have adequate supply of platelet. From this forum, I'll like to caution the public that they should take the preventive measures. That we should, because this is the time. Temperature between 60 and 30. This is the time for breeding of this Aedes aegypti. This Aedes aegypti, which is a daytime biter, this breeds in the fresh water. That is water in the tanks, water in the broken these pots, and these pots outside, flowering pots, and all those areas in near the household, which are we say it's a clean water, where it breeds, and it is a daytime biter. And so what we have to do after 7 days, because the life cycle is such that after 7 days we must change the water. If we are using the water cooler, we must change the water, and we must keep our these tanks closed. We should keep the lid over the tanks, and so we should not allow these things to happen. And if the children are going or adults are going outside, we should ask them to wear the full clothes and use the mosquito repellents. This mosquito, this is very vigorous in biting. They bite at one place, and this usually bites below the knee joints, and it is present in our household near the sofas. So we have to prevent this disease, and public should be not be these alarmed by the mere the name of dengue, because this is just like another viral fever. What we have, if somebody suffers from this disease, what we have to do is we have to take care of our fever. And very important thing which is to be done is we should use only paracetamol. Don't use others like ibuprofen, aspirin, mefenamic acid, because they have the effects on the platelets. So we should use paracetamol and ample quantity of water, and we should ensure that a child should pass urine in 6 hours. And this fever usually lasts for 2 to 7 days, and 5th to 7th, 4th day onward, this is the patient who has a critical period. This is the time when the patient can go into shock. So we have to monitor those patients there. And there are the warning signs. If warning signs are there, like child is having persistent vomiting, child is having pain abdomen, child is lethargic, child well bleeding, and other child is having pain abdomen and liver is palpable, which is non-technical, the technical term for this. So if there are warning signs, then we have to bring the child to the hospital. Otherwise, this is cell-limiting disease, and this goes off on its own without complications. But if these signs are there, then we must not keep the child or a patient at home. They must consult the health facilities, and if need be, these children are to be admitted. So important thing is that child should pass urine within 6 hours and ample quantity of urine. We should give paracetamol and ample supply of water, even ORS.